All right. Well, primarily we're going to focus on some updates with the GINA, which is the Global Initiative for Asthma. They actually call it, they don't actually call it guidelines, but more so like a plan of action, because globally that's what's used pretty widely across the country. In addition to like ATS and other asthma subspecialty guidelines, but GINA is pretty rigorously followed both in the in and outpatient setting. So we'll start with some of those updates and go through things here as we go. We'll start with some basics as well. All right, just a brief bit about allergy and immunology as a subspecialty, because that is what I'm going into. And I think I actually get this question quite a bit. We don't have an allergy and immunology fellowship program here, and unless you have, a presence of an allergy department on the inpatient side or more so in the clinic, you may not know exactly what allergists do. So just very briefly, some topics that you can consider referral in your practice in the future, and things that we asthma an allergist specialist focus on would be, of course, all the things that allergy testing, asthma. Of course, they also manage many conditions in the lung other than asthma, along with pulmonology. They also focus on drug allergy, insect allergy, and vaccines. So they can do drug allergy desensitization and identifying a true drug allergy. So that's something that is really important. Then also drug allergy delabeling. We had a grand rounds on that just a few weeks ago. They're also specialists in immune mechanisms and immunodeficiencies. Allergists do, like in fellowship in particular, you spend about a year doing research. Also, immunologic skin diseases, anaphylaxis, urticaria, and angioedema is a subspecialty of allergy, immune and autoinflammatory disorders. So you'll see that allergists do have some patients they co-manage with, like rheumatology and dermatology. So also infectious disease as well, with both acquired and congenital immune deficiencies. And then food allergy, of course, which is more heavily seen in the peds population, but also in the adult population, of course, too. Mast cell and eosinophilic disorders, rhinosinusitis, and ocular allergy. So some overlap with ENT there. So objectives, we're just going to focus on asthma today. We're going to keep it simple. Definitions, phenotypes, diagnosis, differential, management, and when to refer, which we do manage a lot of these patients in our clinic. So asthma, of course, is heterogeneous disease with many phenotypes, usually characterized as chronic airway inflammation. There's two key features about asthma, which include history of respiratory symptoms such as wheeze, shortness of breath, chest tightness, and cough. You don't have to have all of these, but usually adults in particular have at least two of these symptoms. Your symptoms vary over time and intensity, and you have to have documented variable expiratory airflow limitation. So that's kind of sort of the difference between asthma and COPD, is that you expect asthma to be variable. So it's an important distinction as we start to uptake the new guidance given by the Global Initiative for Asthma. It does affect a large percentage of the population, which makes it very important. So can anyone, if you want to type into the chat, like if anyone can think of some asthma clinical phenotypes that you could think of. I'm sure you all have heard of some of these, but if you can think of any subtypes of asthma, go ahead and list them in the chat or unmute. Exercise-induced, very good. Allergic, absolutely. Very good. So those are definitely a couple of them. So allergic, non-allergic is an important distinction, and which can be, So like the sputum tends to be a little bit different in allergic asthma. If you collect the sputum and analyze it, oftentimes you'll see eosinophils. Allergic asthma is the type of asthma that we typically think of and treat. Patients often also have a history of what, atopy, meaning that they've had eczema, allergic rhinitis, or the atopic march, if you've heard of that as well. Usually you'll see your patients kind of progress through that or they'll have a history of it at least, or family history. Usually those patients respond really well to traditional asthma treatments. Non-allergic, so the sputum tends to be more neutrophilic and contain some inflammatory cells, and that it's less responsive to kind of like ICS or inhaled corticosteroids. Adult onset, which somebody mentioned, which is really important, more common in women. It tends, it presents in adulthood more often than not, can be non-allergic, and then often it requires higher doses of inhaled corticosteroids to maintain control. And occupational asthma should be something that's ruled out or at least assessed in this scenario. So is something, an exposure at work, causing the asthma to get worse. And then asthma with persistent airflow limitation. So that's a distinction between COPD, because asthma can become irreversible. Usually your patient will have a long-standing history of asthma. The treatment is somewhat different, and that's why the distinction is important. Functionally, they start to appear more like a COPD patient, but the distinction is important for the reasons of, kind of down the road treatments are a little bit different in those scenarios. Okay, and history taking. So I basically listed the important things here for us to go over. So again, as in the definition, pattern of respiratory symptoms following an exposure to a known trigger, and resolve with trigger avoidance or asthma medication treatment. So, and then some of your patients will report all 3 symptoms, but some may not. So wheeze, cough, shortness of breath, chest tightness also is something important to note. So positive predictive symptoms, meaning, these are kind of the buzzwords you look for when you're taking a history: episodic, triggers, work-related exposures, personal family history of atopy, and then asthma symptoms as a child. So things that make asthma less likely to diagnosis would include isolated cough with no other respiratory symptoms, especially in adults. Peds may have isolated cough, but adults tend to less likely have an isolated cough only. Chronic production of sputum, shortness of breath associated with dizziness, lightheadedness, or paresthesia, chest pain, and my slide got partially deleted, sorry. Exercise-induced shortness of breath with it, like noisy inspiration is what that's supposed to say. So noisy inspiration is typically not associated with asthma. So something to take note of in your history taking. Can you hear yourself breathe when you're breathing, breathing in or breathing out, or what's hard for you, kind of distinguishing those symptoms? Making the diagnosis, again, you have to have the history of the symptoms that fit with the characteristics of asthma, but also you also have to have confirmed variable expiratory airflow limitation. And what does that mean? I have them listed here. So positive bronchodilator reversibility test. What does that actually mean? Does anyone know? If you want to type it in or say, feel free. 12%, what changes by 12%? 15%, FEV1. Yeah, so this is an important distinction, and sometimes the guidelines or institution you're reading may have, a little bit different guidelines on this, but traditionally what the bronchodilator test is actually doing and testing for is you have to hold your short-acting bronchodilator or for at least 4 hours, or a long-acting bronchodilator if that's what you're on, for at least 15 hours, and you're administered, usually it's albuterol. And then you wait about 10 minutes, and then you do a repeat PFT after you've already done one. So the FEV1 is reduced, and the actual change or reversibility you have to observe is an increase in FEV1 by at least 12%, right? So whoever got that, or depending on what society you're looking at, 200 milliliters. So that's the other cutoff there from baseline. And the important 15% is associated with like a 99% likelihood of asthma, and that's why you might see 15% somewhere. It just increases the specificity, but 12% of 200 milliliters is the actual threshold. Other ways to make this diagnosis, so PFTs with the bronchodilator test is what we traditionally think of, but there are several other ways to diagnose this, and that's because, again, asthma is a triggered related respiratory disease. It's not, so somebody may be in your office and have asthma and have zero symptoms. So like actually catching this variability and is important, and then that's how you make the true diagnosis. So you can have your patient do a peak flow or positive expiratory test at home, and then monitor the variability in that. So if they see variability greater than 10% on diurnal, meaning twice a day, they're doing a peak flow at home, then you can make a diagnosis that way. So you have your patient kind of like ambulatory blood pressure monitoring or something like that. That's how you could make that diagnosis, by finding that variability. Also, if they had increased symptoms, they should check it. They should check their peak flow. But having your patient kind of monitor that at home is an important way, or another distinct way to diagnose asthma. A positive bronchial challenge test, so which is only traditionally done in adults. And reason, we don't traditionally do this in kids, but what actually you're testing for is for a fall in your FEV1 from baseline by 20% with either methacholine, histamine, or histamine. Those are the two traditional ones, or greater than 15% drop in the FEV1 with standardized hyperventilation, hypertonic saline, or mannitol. So usually you'd be referring, sometimes you can do those in the clinic, but if you're actually trying to induce a drop as compared to inducing a positive response, that's something that should be monitored pretty closely, and that's another reason we don't do it in pediatric patients. And the problem with this test too is that it's less specific, right? So COPD, these things could also cause a drop in the FEV1 and in other respiratory illnesses. So that's why it's less specific, but if it's negative, it does help rule out the diagnosis. So that is the meaningful part of the test. And then excessive variation in lung function test between visits. So maybe you get the bronchodilator and you don't, your FEV1 doesn't change by 12%, but maybe it does between visits, depending on the time of year and triggers that you've been exposed to. So somebody asked, if you do a bronchodilator test and it's negative, what do you do? Do you do the challenge test with mannitol or methacholine? You can, but other testing you can do is have your patient do a peak flow twice a day for a week or 2 weeks, and based on the variability, and document what they get. And if they have variability on that test, you can make a diagnosis that way. Or if you get a PFT in one visit and follow up again, and at the next visit, and the PFTs are variable between visits, that can also get you a diagnosis. It just depends on the frequency of exacerbation and things, when you would consider and control whether or not you would do the methacholine challenge. And the reason for that is because it's not a dangerous test, but you're trying to reduce their FEV1, so worsen their pulmonary function. And so it's not without risk, and that's why, you would do that sort of as a last resort in most cases. So flow volume loops are like literally the most confusing thing, I think, but main point of this question is asthma has a along with COPD, but asthma has a pretty characteristic flow volume loop. Can anyone identify as A, B, C, D, E, or F? And these flow volume loops are plotted against absolute lung volume. So the dotted line represents what like a perfect flow volume loop would look like. And then the non or the dark line shows, the pathology. Does anyone know which one, looks like asthma? All right, so the actual answer of true asthma is A, but B also, I can see why you would also think that maybe B. That one is truly a mixed test, and I gave it away here, but this airflow limitation shows this is more traditional asthma. So what we're seeing here is that scooped out appearance will be the term you traditionally see is like a scooped out appearance. And so below the x-axis is actually your inhalation here. You're inhaling, and then this is your exhalation. And so due to the expiratory airflow limitation, you have this kind of scooped out appearance. And so your residual volume is increased compared to baseline on a perfect test. And so that's something you would also look for. And so I'll show you what a flow volume looks like pre and post bronchodilator. Now the X and Y axis are reversed on these next flow volume loops, so that's why it's going to be a little challenging to follow. But so here, you'll notice that when you have, and I said this backwards, I'm sorry, your residual volume is increased in asthma. I apologize, I said that backwards because it's a kind of a double negative. But here you'll see your residual volume falls, meaning you're able to breathe out more, basically. You're able to exhale more because you don't have the exhalation limitation after you've received a bronchodilator. So the pre is this dark line, and then the post is the kind of more, spaced out dotted line. So first you'll see that that the total lung capacity is unchanged after a bronchodilator, but there is a fall in residual volume and an increase in total flow, but not in the peak flow. And then eventually, the bronchodilator over time will cause an increase in flow rates without a shift in lung volume. And so in these first two examples, you can see those here. So eventually, you'll see this happen over time. These are kind of the effects that you can see. So basically the changes that you're seeing in bronchodilation is solely a fall in lung volumes, but flow at any given absolute volume is significantly improved. So the FEV1 may not change in this situation, but you might see an ISO volume shift, as you can see here. So if anyone just wants to type these in, these are more like just kind of rapid fire differentials of patients that you might see in clinic and what other diseases could have some mimicking symptoms to asthma. So an older adult, airway obstruction, less reversible history of smoking. What diagnosis is that? Right, COPD. Absolutely. All right, younger patient, abrupt onset and end of symptoms, monophasic wheeze. This one's a little bit more challenging. You might send them to an ENT. And it's on, we'll say, monophasic inspiratory wheeze. Laryngeal edema, that's so definitely on the right track, something in the larynx, right? Or near there, nasal polyp. So vocal, yes, great, Denny got it. Awesome. So, so that's when you actually have a, paradoxical move in your vocal cords when you should be like breathing in and out. They're actually opening and closing inappropriately, and so you'll go to an ENT and they'll do a nasopharyngeal scope and actually look at your vocal cord and make you do a lot of sounds and breathing exercises to see if they see that paradoxical motion. So something to definitely think about. The picture can look very similar, but often your patients will denote inspiratory problems rather than expiratory. Oops, and I gave that one away since it's pretty obvious. But how about the next one? Cough, productive large amounts of purulent sputum, bronchi, crackles, common wheezing, and clubbing, confirm on CT, bronchiectasis. Awesome. Very good. Recurrent infiltrates on chest x-ray, eosinophilia, high IgE levels, aspergillus antigen sensitization, right? ABPA. Cough productive of a large amount of, again, purulent sputum, bronchi, and crackles, clubbing, maybe have wheezing, recurrent infection. So sort of different, maybe seen in pediatrics more commonly. Great, cystic fibrosis. Sneezing, itching, blocked nose, throat clearing. This one is a little like less obvious. But somebody who has throat clearing all the time, you might think about this diagnosis. Yep, postnasal drip or chronic upper airway cough syndrome is the new fancy name for it. But yes, they're the same exact thing. Local wheezing, and if central in location, flow volume loop may provide a clue. Again, this is kind of less specific, but yeah, mechanical obstruction, very good. Shortness of breath, inspiratory wheezing, stridor. Inducible laryngeal obstruction, so it kind of goes with vocal cord dysfunction. You'll see similar symptoms, but croup also would be similar because it affects your larynx, so very good. And then this last one, shortness of breath, family history of early emphysema. Excellent, very good. So some highlights I want to give on, at least for treatment. First of all would be the goals of treatment. Actually changed in 2019. So let me see, get these pulled up for you. So previously, and I think most of us or many of us in med school learned about symptom control and just asking about symptoms, documenting symptoms, seeing how many times you're using your short-acting beta agonist, and then guiding treatment basically from there. Along with COPD in 2019, the goals of treatment changed from both symptom control but also risk reduction. So you want to maintain normal lung function, prevent flare-ups, prevent asthma deaths, and avoid medication side effects. It seems like those two things would go hand in hand, but they do not always necessarily go hand in hand, and that's why risk reduction became a big guiding part of the guidelines for treatment of asthma. So you also, and then the other thing too is like, it wasn't explicitly stated, obviously you should always have your patient's input, but now it's part of the guidelines is, assess what your patient's goals are. Maybe they're an athlete, maybe they're, an Olympic athlete. So, how you titrate and give treatment will vary based on your population. So make sure you assess all of these things and then pair with your patients in order to find the best treatment. So that was an update from the 2014 kind of report, is to definitely consider risk reduction. And we'll get into why that became important here in a little bit. So I'm not sure if all of you are aware, but as of 2019, the guide or the suggested treatment or guidelines say no longer recommend treating adults with asthma with short-acting bronchodilators alone, meaning we used to just give albuterol when somebody had these symptoms and, told them how to use it, when to use it, and then we would sort of monitor how often they were using it in clinic. But that's gone from the adult side. It's also gone from the ped side, but there are some nuances to that. We won't go into too much detail about the pediatric side. Instead, all adolescents or adults should receive symptom-driven and mild asthma or a daily corticosteroid-containing inhaler to reduce the risk of severe exacerbations. So just giving albuterol is not how you treat asthma anymore, even if it's mild. So the evidence behind this came from a couple studies and then like a meta-analysis in 2018. The two studies that were kind of highlighted, at least in the initial, and there's also ongoing studies as well. But the SMART strategy was a meta-analysis put out by JAMA, and it showed patients showed fewer asthma exacerbations, hospitalizations, ED visits overall when they had an ICS and LABA versus short-acting beta agonists alone. So, and it was mainly pertaining to mild asthma, but it was seen kind of across the board as well. So the ICS LABA group had 23% fewer exacerbations than those with high-dose ICS LABA as maintenance, meaning all of these trials, the ICS LABA was used as the as needed medication. Traditionally, we've always given albuterol and told our patients to use albuterol, or you know, and whatever brand name that might be, but patients always were given short-acting beta agonists to use as needed to control symptoms. But it is now seen that the ICS LABA, which Symbicort is the inhaler that's been used in all of these trials, showed fewer exacerbations when used for symptom control, not as your daily controller medication. But even patients who were on high-dose ICS LABA as maintenance and using short-acting beta agonists as PRN, the ICS LABA group did better when they were using an ICS LABA in terms of a PRN or symptom control management. The other two trials were Sigma-1 and Sigma-2. They were very similar. The Sigma-1 and Sigma-2 actually stand for Symbicort given as an as-needed treatment in mild asthma. So Sigma-1 showed PRN budesonide formoterol was superior to PRN terbutaline and similar to maintenance budesonide with lower cumulative ICS dose. And what that actually was testing in Sigma-1 was terbutaline is a short-acting beta agonist. We don't use it in the US. It's used in Canada, but so patients were given like a placebo controller medication twice a day. Then they were given budesonide formoterol as a PRN to use. And then in the terbutaline group, they were given the patients were given a placebo to use twice a day as a daily controller medication, and then given terbutaline to use as a PRN. And then, and so those were the main outcome was to assess for non-inferiority for the PRN budesonide formoterol. However, it was actually shown to be superior. So what that actually meant was symptom control. That's how they were measured in the first study. So patients like their own perceived symptom control based on they would fill out a questionnaire at each visit, but also they had fewer hospitalizations and exacerbations as well. So it was found to be much more favorable in the Sigma-1. In the Sigma-2 trial, that study was actually looking at budesonide formoterol as a PRN was non-inferior to BID budesonide for rate of severe asthma exacerbations, but was inferior for symptom control. So what they were actually testing in this study was budesonide formoterol was used as a PRN. Again, these patients were given a placebo to take twice a day as their maintenance therapy. And then the other group was given BID budesonide at a medium dose. So they were given like medium dose budesonide and then given a short-acting beta agonist as their PRN. So severe exacerbations were about the same in both groups. Patient perceived symptom control was a little bit worse in the budesonide formoterol PRN group, but the actual severe exacerbations requiring hospitalization and treatment were the same. So it was like non-inferior from a severe asthma exacerbation standpoint. So another piece of evidence in this change is that particularly in mild asthma, those patients that we were just putting on PRN albuterol up front, even though they have mild asthma, having mild asthma and infrequent symptoms doesn't mean that your risk of adverse events or how severe your adverse events related to exacerbations can be. So that's kind of the thing that was found, is that 30 to 37% of adults could develop acute asthma exacerbations despite only having mild asthma classification. 16% of patients with mild asthma have near fatal asthma, and then 15 to 20% of adults with mild asthma have die with asthma exacerbations. So meaning just because your symptoms are infrequent doesn't mean they cannot be severe, is basically the takeaway from that. And then exacerbation triggers are variable, and depending on how big your exposure or trigger is, you're still at risk to develop a severe exacerbation. And then again, the other thing that was found is that short-acting beta agonists or frequent use is actually associated with adverse events. So you see some beta receptor downregulation, decreased bronchoprotection, rebound hyperresponsiveness, and then decreased bronchodilator response over time. Increased allergic response and increased eosinophilic airway inflammation has also been observed. And then just kind of generally, if patients have greater than 3 canisters per year of albuterol administered, it's associated with higher risk of emergency department presentation. So just having a patient of yours who fills albuterol all the time has been, associated with a higher risk of death too. Okay. In the past, and this is just like the way asthma treatment is approached, and we'll go into detail in just a second about what that actually means. But in the past, we just used to ask about exacerbations and perceived control of symptoms with asthma, and then titrate medications solely based on that, as compared to actually, remeasuring lung function visit to visit, asking about flare-ups, hospitalization, sort of like what we do with COPD. So our treatment is guided more in conjunction with symptoms plus risk reduction. So if you've had an asthma exacerbation, despite being adherent to your treatment, that means that you, at least in the short term, qualify for a step up in therapy. And so it used to not be as much about normalizing lung function or preventing flare-ups. It used to be more about how many times did you have to use your short-acting beta agonists? And that was pretty much where the end of the questions were. And how often were you using it at nighttime? How often were you waking up feeling short of breath or using, so things used to be mostly based solely on how much you're using your albuterol inhaler. And then short-acting beta agonist was also found to be associated with adverse events. Just the medication itself causes tachycardia, rebound, hyperresponsiveness. So it just has been associated with, even though it's been the mainstay of treatment for 50 years, these new studies are showing that asthma is, because it has this inflammatory and reversible airway obstruction, that steroids truly are the mainstay of treatment. And that's why they help prevent exacerbations and control symptoms better overall. And why Symbicort was actually chosen is actually important as well, because Symbicort has formoterol, which is a long-acting beta agonist. However, it is the only one that works quickly. So it's a long-acting beta agonist, but it also, its onset to effect is rapid, sort of like a short-acting beta agonist. So you get rapid relief with sustained response. So here's the updated kind of step up in therapy that you've probably seen many times. It's been changed a little bit in the most recent iteration of these this initiative from Gina. So this came out, I guess, at the end of 2020, this info. But one important key aspect about asthma treatment is to assess. So you always want to make sure you have a confirmed diagnosis. So this part of the circle here, assess symptom control and modify risk factors, because again, this is trigger driven disease. You also want to assess comorbidities, always assess inhaler technique and adherence, and then what their patient's goals are. Adjust treatment based on modifiable risk factors, comorbidities, try non-pharmacologic things. You can adjust the medications, obviously, and then educate your patients, and then review response. So this is just kind of a continued cycle. You want to assess for exacerbation, side effects, measure lung function, and how satisfied your patients are with their treatment. So this actual treatment step-up therapy is different than what we are used to using in the past. So step one in a patient, and we'll go to the different levels of asthma and how to classify them in just a second. But now, as opposed to short-acting beta agonist in the step one of therapy for asthma, for your mild intermittent patients, you would instead use a low-dose inhaled corticosteroid plus formoterol. That's right. I think, who said that, Kushbu? Yeah, so I saw, because I actually used your MixApp 18. Some of the questions now have highlights saying they removed some of the explanations, but yes, MixApp 18 doesn't fully reflect this. Some of the newer questions that come when you have like those updates do reflect it, and I did confirm that MixApp 18 did have like the new guidelines on asthma imported into the literature that it gives you. So as needed, Symbicort is your step one. The other controller option is you can do a low-dose inhaled corticosteroid without the formoterol, but you would also administer a short-acting beta agonist at the same time. So basically, you're administering a short-acting beta agonist as compared to a long-acting beta agonist in step one. Step two, you would do a low-dose ICS, or if you chose the other option, you could do an as-needed low-dose ICS formoterol. Another way to step up therapy would be to add something like montelukast, or you can continue the step one therapy and add the low-dose ICS and then give a SABA. So step one and step two kind of depend on where you start, how you would adjust to step two. For step three, you would do a low-dose ICS LABA, and that's why it doesn't say ICS formoterol, is because depending on what inhaler you actually prescribe, fluticasone and salmeterol. So it depends on the insurance too. So that's why there are many different options. Insurances should cover Symbicort now. Most of them should as a PRN, but low-dose ICS LABA would be your step three. Other controller options would be medium-dose ICS or low-dose ICS plus something like montelukast. That would be how you would step up therapy. So where these two areas kind of diverge a little bit is that your PRN should theoretically be Symbicort, unless you're doing this second treatment option here and using a short-acting beta agonist. However, this should be your reliever medication. And step three, depending on what your maintenance or controller medication is, if it is your maintenance is Symbicort and that's what your insurance pays for, then you would continue to use Symbicort as your reliever medication as well. However, if your insurance, approves something else like, Advair, for instance, or, Air Duo, like Chris said, then in that situation, you can do a short-acting beta agonist as your maintenance therapy, or your reliever therapy, I'm sorry. It just depends on what your maintenance therapy is. that's how you choose what your PRN is above step two, because no insurance is going to cover, in theory, at least not at this point, Symbicort to use it as a PRN and Advair as a controller. And so that's where that discordance comes in. And so depending on what your low dose ICS LABA is, your PRN will be different. And that's kind of confusing. So feel free to ask questions about that. That is something that is new and different than before. But I think the guidelines kind of take into consideration what in reality you'll be able to actually get prescribed. So there's that. And then at step 4, you'd step up to a medium dose ICS LABA. You can also do a high dose ICS plus add on tiotropium or montelukast if you haven't added it already. Again, your PRN medication would depend on what your controller is. So it'd either be something like Symbicort, or you can also use a short-acting beta agonist in this group. And then step 5 would be high-dose ICS LABA, refer for phenotypic assessment, consider add-on therapy with tiotropium, IgE. You can do additional lab work with IgE, IL-5, IL-4, and then add a low-dose oral corticosteroid if you're needing that much. Depends on where you are in their treatment, whether or not you would add that on. So very different than before, at least in these kind of initial stages. And again, how you correlate with symptoms or your classifications of asthma are shown here. So symptoms less than twice a month. So that's your patient who has mild intermittent asthma. Symptoms twice a month or more, but less than daily. So you have mild persistent asthma, and then you sort of get into the moderate persistent and then severe asthma here. So, and then when you're getting up towards step 4 and step 5, at that situation, you consider referring them to a pulmonologist or an allergist for additional considerations of therapy. But the important part about this is initial controller medications. Depending on where you are in these steps, you can always also go up or down, depending on how well you're controlled, how often you're having exacerbations, or if one medication's tried and doesn't, the patient doesn't like side effects, you can step between these steps depending on what's going on. These are the initial points, but the highlight about this is to always kind of go back to this paradigm about assess, adjust, review, response, and that's how you step between these therapies. There are some explicit instructions of what to consider doing, but kind of the beyond the scope of this talk. Usually we can kind of get you kind of get a feel for that in the clinic. Along the way, make sure you're assessing these things too. Always assess that your patients are using their inhalers correctly. Certainly I've seen people use them incorrectly. So what's your max daily dose, right? So since we're puffing the Symbicort a whole bunch of times a day, what is the maximum dose? So when it's prescribed in maintenance and reliever therapy or as needed, or within an action plan, so your max dose is 72 micrograms of formoterol per day. So that's 12 inhalations. And that's like your meter dose inhaler that you administer in this situation. So you can take 1 puff twice a day, and then you can take up to 10 puffs for relief therapy if needed. Beclomethasone and formoterol, we don't actually have this combo in the US. So I think this might be in Canada, but again, it just gives the total daily dose that you can take. So that's the important thing too, is if you're using this, you have to tell your patient how many times they can use it in a day before they've kind of like overdosed on their Symbicort, basically, because there does need to be a limit. But in reality, this ends up being less than a high, like if somebody's on a high dose ICS daily, the amount of inhaled corticosteroid is actually lower overall based on how much is used. So that's another important highlighted point, is that you actually get less of the steroid component this way as compared to having to reach up to high dose ICS more frequently for maintenance therapy. And this is sort of like, think of this as your topical steroid chart, or like your statin chart. So the important point about these is this is your dose to switch between low, medium, and high. But these don't mean these are equivalent, right? So like our statins, they fall into high intensity, medium intensity, and low intensity, but doesn't mean they're equivalent. So oftentimes this is guided which one you actually choose, unfortunately more by insurance than anything else. But knowing where these dosages fall within each medication is the important takeaway here. So a black box warning was added not too long ago in 2020 for montelukast. It was known that it can cause mood effects, but now it's been upgraded to include suicidality. Suicidality in adults and adolescents, nightmares, and behavioral problems in children. So make sure you assess risk factors for this in your patients before you prescribe montelukast. Before, it was just a rare side effect listed in mostly females, but apparently this side effect has been found more commonly than previously thought. Oops. All right, strategies to choose the inhalers that you give. Obviously, you choose the steps in therapy to help guide you, but the actual devices themselves, here's a nice little chart that kind of details what to consider, like if your patients have arthritis, or aren't very coordinated, or have weak thoracic muscles, or whatever it may be. You can consider the type of inhaler to give, because a lot of these inhalers are prescribed in different types now. So I'm talking about like meter dose inhaler, or like a nebulizer. So how you choose, honestly, at the end of the day, ends up being more commonly, unfortunately, again, associated with what insurance will cover. But knowing how to teach your patients how to use each type of inhaler is important. So like you dry powder, you need to store, like you need to make sure not store sideways or on its side. And then you also need to rinse your mouth out when you use those. And then a meter dose inhaler, oftentimes patients have a hard time coordinating the puff with their inhale, and so spacers are often used with those. And then you have things like your Spiriva, that's like actually like a soft mist inhaler. So knowing how to, or having someone at least in your clinic who knows how to teach your patients is important. The Quad AI has videos. This inhaler, this website is literally just about inhalers, and that's where I pulled this from. You can pull up some teaching videos on those, because oftentimes, exacerbations is related to inappropriate use of inhalers from a technique standpoint. So make sure you know how to use them if you're prescribing them. Okay. So briefly on asthma exacerbations, I'm not going to go into too much detail on this. We see them more commonly in the hospital setting, and I think pretty well, like the treatment guidelines on that has not changed recently, so I won't go into too much detail about that. But basically identifying, this is just an algorithm that I thought kind of encompassed it pretty nicely, even though it's a busy chart. But identifying the exacerbation is important. Breathlessness at rest, drowsiness, agitation, speak in full sentences, and is their peak expiratory flow less than 50% predicted or their personal best? That's an important thing to highlight. And you'll see in the ER actually that they do peak flows down there to help triage and determine whether or not to send patients home. So, so if patients have risk for fatal asthma, or a worsening exacerbation, like a comorbid condition, that would be like obesity, chest pain, fibromyalgia, sputum production, or if they've had a history of a severe exacerbation in the past, then in that situation, you would proceed down to the yes section. You would either treat, like they need to come to the clinic and be evaluated by their provider if they're calling in, or go to the ER. They can use their short-acting beta agonists, and then also consider epi injection if they have something like food allergy or severe allergies, because asthma can certainly be triggered by these like food allergy or other things if you've had an exposure. So if the patient already has signs and symptoms of a severe life-threatening exacerbation, the patient needs to go to the ER. And in that situation, preferably by ambulance, they would give albuterol, which we see done. They should use their albuterol rescue inhaler, and they can use a spacer. More than likely, they'll get steroids and then supplemental oxygen if needed. And then if your patient doesn't need to go, if they just need to be evaluated in the office, if they are doing okay enough or don't have significant comorbidities that will require transport to the ER, then you can continue home management with albuterol. You can do longer treatments at home, and you can adjust the controller medication as well if needed. And then, so you can basically do a step up in therapy. Oftentimes it's for a week or 2 weeks, and then consider whether or not you need to step down. They say assess response after 3 doses. That's in the acute setting, but in the kind of subacute setting, you'd probably just step up in therapy. So if they have a good response to the treatments in the office or at home, then their peak flow improves, which again, the ER, you'll see often repeat a peak flow after treatment. They'll give like an hour-long albuterol treatment, then they can go home and do some steroids, increase their controller medication, continue their short-acting beta agonist. If they don't have a complete response, then again, start steroids, consider admission to the hospital or move to the ER if that's what's needed. And then worsening symptoms, despite all of those treatments, your peak flow actually gets worse. Your patients, have lost their wheezing sound and they're starting to fatigue, then they need to either be in the ER or be admitted. You always want to start the short-acting beta agonists and take oral pred in the meantime. In that situation, you'd also consider giving magnesium, although this is outpatient exacerbation, and so that falls more into the inpatient exacerbation territory. But magnesium is still given, hour-long albuterol treatments, all of those things that you think about. Basically triaging whether or not your patient needs to go home and start steroids and increase their controller therapy, as well as their PRN use of medications, or if they need to go to the ER is important. So after your patient's on one of the steps in therapy, then you want to continue assessing for symptom control. And so that's kind of more of an objective scale here. But then also you want to assess with the, there's a few different scoring systems that I didn't pull in here, but like the ACT, there's Asthma Control Questionnaire. Basically, it asks about all the things that you should be monitoring for in your treatment plan. Again, these are things you can print off in clinic and give to your patients and keep on file. But kind of beyond, didn't want to be beyond the scope of going into explicit detail. But always assess for control of your patient's asthma in the clinic, especially if you're their provider for this. Oh, and this kind of designates in the new guidance, I'm sorry, that if your controller medication is the ICS formoterol, like in the step 1 of therapy for asthma, that you wouldn't count that per se towards exacerbating symptoms, because it's also considered your controller therapy. So that's still being analyzed as to how to classify symptoms in that regard if you're on a PRN ICS formoterol only. And if you're on step 2, sort of if you're in that category as well. It's kind of a gray area at this point, but so that's something that is currently being investigated a little bit further. So another really important thing to consider is comorbidities in your patients when trying to manage and step between therapy, especially in occupational asthma, athletes, pregnant women, geriatric patients, patients with obesity, smokers and ex-smokers, low resource settings, or patients who have lower resource availability. The reason I mention that is because in these situations where the patients are becoming difficult to manage or they're not responding, in that situation, you might consider referral. But some highlights on these patients are occupational asthma and work exacerbated asthma. Avoidance actually is a key to these patients, and unfortunately, that may mean changing occupations, and that's never what anyone wants to hear. But identifying and stratifying risks of exacerbation is important. Another thing would be athletes, of course. What can they take? Can they not take? If they are competitive in sports. Pregnant women, treatment ends up being identical pretty much. You avoid, the oral steroids if possible, but at least the initial treatment and continuation of treatment ends up being about the same. And obesity, that weight loss is actually part of the asthma treatment plan. For lower resource settings, you want to consider how to get your patient the cheapest and most cost-effective medication, and being more, creative with that becomes very important. COPD asthma overlap, and I mentioned this because we see so many patients who sort of have one diagnosis or not the other, and with the shift in paradigm for treatment for asthma, this becomes more important than what it was before. The treatments sort of used to be a little bit more similar, but the big key takeaways are asthma should never be treated with bronchodilators alone, for the reasons we talked about. COPD, you start treatment with a LABA and or LAMA without ICS, because high-dose ICS is associated with worse outcomes in COPD patients. So they're sort of reverse. The asthma patients who have reversibility respond really well to steroids, whereas the COPD patients who have less reversibility do not respond as well to ICSs. So they have increased mortality and risk of hospitalization. So if they're on a high dose ICS. So that's really the key to this, is why it's so important to delineate this diagnosis. And then features, I don't know if this, my internet's unstable. Sorry, I'm in the hospital. I don't actually know if it's messed up, but basically, if you have, clinical phenotypes and then assess based on your PFTs, if your patient more likely has asthma, don't give the LABA and or LAMA without ICS, and avoid maintenance oral steroids if you can. If you have features of both asthma and COPD, meaning you have some persistent expiratory airflow limitation, but maybe you have some bronchodilator reversibility, the main takeaway is you're going to sort of treat as asthma still until you've documented that your symptoms and lung function is no longer reversible. So again, don't give LABA and or LAMA without the steroid, and then avoid oral steroids if you can. And if the patient more likely has COPD, treat them as COPD. And so in this situation, you're going to avoid the high dose ICS, and all patients avoid oral steroids if you can. And then reliever containing your inhaled corticosteroid is not recommended. So that's the important key too for COPD. So COPD patients can take Symbicort twice a day, but they would use a short-acting beta agonist as their PRN, whereas the asthma patients would use the Symbicort as their PRN, as an example. And that's a big highlight and a reason why you would not treat these patients the same way, and why you want to have a diagnosis if you can get one. All right, when to refer. Difficulty confirming the diagnosis. Occupational asthma can be notoriously difficult to treat. So that might be a situation. Patients with persistent or severely uncontrolled asthma or frequent exacerbations. Any risk factor for asthma-related death, meaning hospitalization in the past, or severe exacerbation requiring hospitalization. High-risk treatment side effects for patients who are immunosuppressed or have other comorbid conditions that make the use of ICS, LABA difficult, or steps up in therapy difficult based on other conditions that they have. Maybe they also have a cardiac condition, things like that. And then if they have complications or subtypes of asthma, you might want to consider referral as well, because there may be additional treatment options if they fall into that sort of severe subtype asthma that we talked about earlier in the talk. That's, you would consider referral if you're kind of at the end of your rope. So uncontrolled asthma, difficult to treat, and then let's see, and then severe. And there's kind of some differences and nuance between them. Uncontrolled, meaning they have frequent exacerbations. A lot of times patients have mild asthma, but you want to certainly reassess if they're taking their medications regularly, if they're taking them appropriately, monitor use. So if patients are having frequent symptoms and or flare-ups, you may consider a step up in therapy, or readjust and reassess how they're using their medications. Difficult to treat patients, their asthma is uncontrolled despite prescribing high-dose preventer treatments, and then they also you could consider your diagnosis, inhaler technique, always like you do anything else. But your patients aren't responding to high-dose intense therapy as you would expect. And then severe asthma it's been difficult to assess and give a true definition for, but it is defined as asthma that's uncontrolled despite optimized therapy and treatment of comorbidities. And then if the symptoms worsen when high-dose treatment is decreased at all. So sort of relatively refractory asthma, meaning they're requiring steroids, or anytime you try and step back from some oral steroids, they have exacerbations, things like that. And you've already assessed for all the other things we talked about. And so here's so we got to step 5, which is listed here in this diagram. When you're at step 5, which is, you're kind of at the end of your rope in terms of what you can treat with in the office. You've given them the high-dose ICS. They're using their ICS LABA as a PRN. They've tried montelukast. They've tried, different therapies to step up their therapy. They've required some oral steroids. In that situation, you'd want to consider what's called type 2 inflammation, which is an added risk factor for severe asthma. And how you would initially work that up, or what an allergist would do, because usually you refer in this situation. You could check eosinophils, a pheno, which is exhaled nitric oxide. You can check sputum eosinophils, and do some allergy testing, especially if they describe allergy-driven symptoms. And you can consider putting your patients on the oral steroids if needed. And then if they're on oral steroids already, you need to get them on the lowest possible dose to check these labs. So here's some additional lab work you can do to further work up these patients, ensure that they don't have another condition that you're missing, get an ANCA, CT sinuses. Do they have chronic sinusitis, maybe an immunodeficiency? Do they also have heart failure on top of this? And then consider referral at that situation. Other things to consider would be these kind of substratifications, aspirin-induced, asthma, as well as ABPA, chronic rhinosinusitis, nasal polyps, atopic derm. All of these things have type 2 phenotypes, and you can add on therapies. And then if there's no evidence of a type 2 inflammation, then again, you need to reinvestigate, make sure you have the correct diagnosis, avoid exposures, consider a bronch or high-res CT, or you can try some of the other add-on therapies. Last line, if you just truly have severe asthma and no type 2 inflammation, you can consider bronchothermoplasty, which is sort of like an advanced therapy for COPD, but it's different in the fact that they actually sort of dilate the airways to help fix the obstruction, and it's done with thermoplasty. So it's definitely different than the valves we put in for COPD or lung reduction surgery, but it is an endobronchial procedure to help open up the airways, basically, and it's a last resort. And so if you're kind of at this point and you found evidence of type 2 inflammation, then you can try a biologic. All right, as some biologics that are available, omalizumab, which would be for elevated IgE. Patients who have elevated IgE levels, you can add That was one of the first ones. Omalizumab, your levels have to be between 30 and 700. It's sub-Q. There is actually a risk of anaphylaxis with the first few doses. You have to stay in the office when it's administered. There's some adverse side effects listed there. And then eosinophilic subtype of asthma has more treatment options. Dupilumab was one of the most recent ones added. It has an IL-4 receptor subunit that it's a monoclonal antibody. And then there's mepolizumab, benralizumab, and resilizumab. They each have their own indications. Again, most of the time it has to do with the peripheral eosinophil count. And in both situations, if your patient's on an oral steroid, like you either have to wean off and be on the lowest tolerated dose or discontinue for about a week and then reassess. So I've got some questions here at the end as well. I know we talked a lot about some of the big updates and takeaways. These are from Mixap, so I chose questions preferentially that have been updated, but anyone wants to type in an answer. 32-year-old evaluated for symptoms of persistent asthma, was in the ED 2 days ago, shortness of breath accompanied by wheezing, dysphonia in upper chest and throat tightness. Albuterol didn't help. IV methylpred did not help. He was hospitalized. He was diagnosed with asthma in high school and has required several courses of prednisone per year. Currently taking albuterol, fluticasone, salmeterol inhalers, prednisone, and montelukast. On exam, the patient has normal blood pressure, heart rate's 110, respiratory rate's 18, statting 100% on 2 liters. Labs show normal CBC, metabolic panel, and IgE are all normal. Chest X-ray is normal. Bedside spirometry is normal. What is the most appropriate management? Good, because we got laryngoscopy. So in this situation, your patient's not responding to anything you're doing for asthma management, and they have normal spirometry. In that situation, you need to reevaluate. So this patient could potentially have vocal cord dysfunction. He has the chest tightness. He has triggers. Things like perfumes and irritants actually can trigger vocal cord dysfunction, or even emotions. So it can be like severe. So that's why you want to assess, especially if the patient's not responding to high dose treatments for asthma. So I thought that was a pretty good question. And then a 49-year-old evaluated in the office for a recent hospitalization for asthma. Symptoms have improved, but continues to have shortness of breath and intermittent wheezing. She's had 2 other hospitalizations within the past year for asthma, despite chronic use of oral steroids. Other than a 3-year history of asthma, her medical history is unremarkable. She takes mometasone, formoterol, montelukast, albuterol, tiotropium, and prednisone. On physical exam, vitals are normal, oxygen's 95% on room air. Home exam reveals expiratory wheezes with good air movement. The remainder of the physical exam is unremarkable. Lab tests show white blood cell count of 10,000, 650 eosinophils. Serum IgE is 12, which is within normal limits. FEV1 is 56% of predicted. Chest X-ray is normal. What is the most appropriate treatment? I don't know what happened. Oh, I gave it to you. I don't know what happened. My slide skipped ahead, but great. Mepolizumab. So that's one of the therapies. Omalizumab is indicated for serum IgE levels that are elevated. So if your eosinophils are high, then it's probably going to be one of the other options. Mostly is the takeaway. There's more nuance to that, but that's why you refer to an allergist. And then my resources got cut off on this, my presentation. So normally I would have a resource slide here, but I don't. So I apologize. If anyone needs resources, I've got them.